Hi, my name is Joseph Potter. I'm a professor of sociology at the University of Texas at Austin and the principal investigator of the Texas Policy Evaluation Project, or TexPEP. This is a collaborative group of university-based researchers who evaluate the impact of legislation in Texas related to women's reproductive health. Today we'd like to share with you highlights from an article published in Obstetrics and Gynecology, the Green Journal, in August of 2017, this last summer. It's entitled Contraception After Delivery Among Publicly Insured Women in Texas, Use Compared with Preference. What I'm going to show you are results from a prospective follow-up study of 1,700 women who were recruited shortly after delivery and will be followed for 24 months. The main inclusion criteria were having the delivery paid for by public or no insurance, age 18 through 44, speaking English or Spanish, and living within the hospital's catchment area. Recruitment took place in 8 hospitals located in 6 cities. The cities were Austin, Dallas, Edinburgh, El Paso, Houston, and Odessa. The hospitals varied by ownership, teaching status, and included private and public and doctor-owned institutions. The baseline interview took place in the hospital just after delivery, and then we had follow-up interviews by telephone at 3 months, 6 months, 12 months, 18 months, and 24 months. Enrollment started more than 2 years ago, and we're now almost finished with the 24-month interviews. The main distinguishing feature of our questionnaires was that we asked people not only about their use of contraception during the course of the study, but also about their preferences and demand for specific methods. We got at preferences through a series of questions in the first 2 interviews. The first was a direct question. What method would you like to be using 6 months after delivery? This question was followed by some probe questions for people who might have been influenced by their own financial constraints or the practicality of accessing certain methods. 2 of these probes were, would you like to have been sterilized at the time of your last delivery? And would you be interested in using LARC if you could get it for free? I'll move on to the results. The first one is the difference between use and preferences that may be seen in these 3 pie charts. The pie on the left shows actual use of contraception in the study cohort at 6 months after delivery. 2 specifics I would call your attention to in this chart are that 42% were using less effective methods, condoms and withdrawal in the large majority, and 22% were using LARC. The second pie, in the center, is what you get based on the simple direct question asked at 3 months about the method the participants would like to be using at 6 months. You can see that there's a substantial difference in the desired method mix as compared to actual use in the pie to the left. The preference for LARC is 34%, and the proportion of women who would prefer to be using a less effective method has shrunk to 13%. The last pie on the right shows what we call elicited preference and incorporates the probes. It also gives priority to sterilization in the case of a woman who said both that she would like to have been sterilized at her last delivery and that she would be interested in using LARC. In this pie, the demand for less effective methods has shrunk to 5%. There are 41% who are interested in or would like to be using LARC, and 36% who would like to be using a permanent method. Before showing you the next result, I need to provide a bit of background. Only one of the hospitals in our study, Hospital 8, offered immediate postpartum placement of IUDs and implants. The hospital in question served a largely Hispanic population and had access to funding from their local hospital district to cover the costs of the devices. Since on January 1, 2016, Texas Medicaid changed its rules to permit reimbursement for postpartum LARC, this option is now possible for other hospitals. So the next slide shows actual use over the first 6 months after delivery for Hospital 8, and also for the 7 other hospitals that did not offer immediate postpartum LARC. It's just tracking actual use over the 6 months following delivery for both groups. Over on the left hand are hospitals 1 through 7, where no participant is using LARC at the time of the baseline interview, and LARC use eventually grows to 20% over the 6 months. But at the hospital offering immediate postpartum placements, Hospital 8, they start with 36% using LARC, implants or IUDs, and that stays constant all the way to 6 months. So there's a substantial difference between Hospital 8 and all the rest. The other results from these data that are in the paper came from multivariable analyses that we ran to see what factors, other than hospital, which is adjusted for, led to greater or smaller chances of getting a highly effective method, given that you wanted one. Amongst the people who wanted more children, the 2 factors that stood out were being foreign-born, which is a proxy for documentation status. This is not to say that all people who are foreign-born are undocumented, but a fair proportion of the foreign-born women in Texas lack citizenship or legal residency, which makes them ineligible for most of the state's family planning programs. The second factor that was strongly correlated with a woman's chances of using her desired method was whether she obtained prenatal care at a public clinic or through a private provider. And incidentally, we observed a large and smooth range across the hospitals in the study in the proportion of public patients who had private prenatal care. Among the people who didn't want to have children, the same factors were associated with the likelihood of using a preferred method. But in this model, there was one more significant predictor. Non-Hispanic blacks were especially unlikely to get their preferred method, often a desired sterilization. So to wrap up, we think there are 3 main findings and several implications for policy. The main findings are a considerable difference between use and preference, with substantial unmet demand for postpartum LARC and sterilization. Second, unmet demand is especially pronounced amongst foreign-born, who are less likely to qualify for state programs, and among women who deliver with private prenatal care. Finally, LARC use among women delivering at the one hospital offering immediate postpartum LARC was much higher than it was among women who delivered at the other hospitals. There are 2 pretty clear implications for policy. First, there's a huge opportunity for immediate postpartum placement of IUDs and implants in the public patient population in the state of Texas. Second, the extension of coverage for family planning for undocumented women for 60 days or more past delivery could reduce unintended pregnancy and the frequency of short interbirth intervals. I'd like to close by acknowledging my co-authors and our funders. I'd also like to thank you for watching this video. If you'd like more information or a PDF of the paper, please write to me at the address shown, and I'd also like to invite you to visit the TexPep website. Thanks again.